Okay, good morning, everyone. Welcome back to our grand round. We did have a little hiatus there. This morning, I have the distinct pleasure of introducing Dr. Larissa Dursko, who is a uveitis specialist and the former chief of the uveitis service at the University of Toronto. Based primarily at a Unity Health, she works at both St. Michael's and St. Joseph's Hospital here in Toronto, as well as the Kensington Eye Institute. And she's been long a steward of the uveitis program at the University of Toronto and a great contributor to the residency program, especially with respect to her uveitis teaching at St. Michael's Hospital. She completed her residency originally at the University of Toronto with further subspecialty training in uveitis at McGill, and I look forward to her talk this morning. So Dr. Dursko, the floor is yours. Thank you for your time.
Thank you very much. And it's now my pleasure to introduce our residents who were two of our senior residents who will be doing the presentation today. So I'm going to let them take it away in just a moment. Seema Emami is PGY5, actually recently graduated and our newest faculty member and at the University of Toronto, and Austin Pereira is a PGY4 resident. And it really has been my pleasure to work with these two residents, and both demonstrate a special interest in uveitis during their residency training. They'll be talking today on Beyond the Vaccine, Uveitis in the Era of COVID-19 Immunization.
Thank you very much for having us. Thank you, Dr. Dursko, for being a great mentor. We've been working actually on this project with Dr. Dursko for quite some time now, and it's really exciting to be able to share this really salient information with everybody. So without further ado, jumping right into our topic, I'd just like to start by mentioning that before we get into the specifics of COVID-19 immunization and the effects that they have on the eye, it's important to acknowledge that in the general population, the benefit of immunization against COVID-19 vastly outweighs the associated risks. And there is no evidence at this point to suggest that patients should avoid vaccination on the basis of ocular complications. So although we're going to delve into specifics and talk a little bit about what can happen in the eye after immunization, we just want to start from this common ground that still, despite everything we'll talk about, the benefit of immunization is still very, very strong. So we'll start with a poll question for the audience to see where we're all at. I'd like for everyone to think and answer, what is the most common type of uveitis that we see following COVID-19 immunization? Our four choices are anterior uveitis, panuveitis, white dot syndrome, and retinal vasculitis. So I'll give a minute for everybody to respond there.
So it looks like the majority of your audience, Seema, thinks it's anterior uveitis.
Okay, all right. Well, let's dig right in and we'll see where we end up based on our presentation. So our first case is a 54-year-old male who presents with bilateral eye pain to our clinic with redness for the past 2 days. He's very healthy, has no past medical history, and has never needed to see an eye physician before. On examination, his vision is preserved at 20/25 in both eyes with normal intraocular pressure and pupils. His examination is pretty symmetric in both eyes with 1+ conjunctival injection and a clear cornea. In the anterior chamber, which is deep, he has 1 to 2+ anterior chamber cell reaction. And there's mild posterior synechiae in both eyes. And you can see from this image where the synechiae were before they were broken. The lens is clear and the fundus exam is normal without any vitritis or chorioretinitis. So putting this together, it seems like a fairly straightforward case of bilateral non-granulomatous anterior uveitis. So we start the patient on topical prednisolone acetate 4 times a day in both eyes. The patient responded well to treatment, although he needed to have treatment for over 6 months due to a chronic and relapsing course. Now, as in all patients with first presentation of uveitis, we did a careful review of symptoms, and nothing came up in terms of uveitis risk factors, except for the fact that this non-granulomatous anterior uveitis began 2 days following his most recent dose of the COVID-19 booster. Interestingly, he hadn't had uveitis following previous doses or after any other immunizations on which he was totally up to date. And so this gave us pause to think, could there be a link? We then, sometime later, had a second case that we'd like to share. A 29-year-old man this time presented with blurred vision in both eyes for about a week. This patient had been known to us previously. He had had an episode of idiopathic bilateral non-granulomatous anterior uveitis that had actually presented in India and was treated by a prominent uveitis specialist there. They'd done a full workup, which was negative, and this man had at this point been quiet without treatment for over a year. Otherwise, he was perfectly healthy and on no medications. When he presented to our clinic here in Toronto, his vision was 20/25 in both eyes. And again, he had a fairly symmetric presentation with 2+ cell in the anterior chamber and 1+ cell in the anterior vitreous. His fundus examination showed that mild optic disc hyperemia and mild CME on OCT. Based on his findings in the clinic, he underwent an IVFA, and I'm wondering if there is perhaps a PGY3 who'd be able to point out the most salient finding in this IVFA.
We'll get someone in the room.
And actually, we'll open it to anybody who'd like to jump in there.
Go ahead. Yeah, go ahead. Oh. Mohammed, why don't you try, Mohammed? I'll turn the lights down.
Of course, this is just whatever that you see, there's really no wrong answer here.
I can try. So in the IVFA, more peripherally, there's large areas of vascular leakage, more on the left and the right. So there's probably like a vasculitic component.
Perfect. Thank you so much. So you can see here in this late phase IVFA that there's hyperfluorescence in the far periphery, in keeping with peripheral vascular leakage. And as I think that was Ryan said, in keeping with a possible vasculitis. And that's exactly what this patient was felt to have clinically. Again, looking for an inciting incident, this patient had had the second dose of the Moderna COVID vaccine 20 days prior to the vasculitis onset. Previously, following his vaccines, he had not had any history of vasculitis, and actually in total, he had not had any posterior uveitis or vasculitis and no other side effects following his initial vaccine. This patient, given his bilateral posterior involvement, was treated with prednisone 1 mg/kg orally, and he did do quite well initially. However, he did recur upon taper of the corticosteroids, so he was therefore transitioned to systemic methotrexate. To date, he has remained quiescent on this regimen with preserved visual acuity and no further flare-ups.
Thank you, Seema, and I'll take over for mystery case number 3. We have a 28-year-old woman who presented with painless decreased vision in her right eye. The past medical history and past ocular history was unremarkable, and we took a comprehensive review of systems, and the patient did have their 2-week post-Moderna vaccine, their second dose, 2 weeks prior to presentation. So for this patient, her visual acuity was 20/60 in the right eye with no improvement on pinhole, and 20/20 on the left eye. There was no RAPD, and her pressures were within normal limits. Her anterior segment was normal as well, and her fundus examination was demonstrated here. I'll say here, but before I go on, the left eye's fundus examination was normal. So here we have the right eyes. And could I get maybe a PGY2 to describe the fundus findings in this right eye? Or anyone. Won't be picky.
Let's get someone in the room to volunteer.
You like it? You try.
Sure. So it's a color fundus photos of the right eye. The media looks clear. The nerve looks okay. Vessels look okay. But in the macula, it looks like there's some pigmentary changes with possibly an abnormal foveal reflex.
Perfect.
Yeah, that's fantastic, Yusuf. That's great. And you can really kind of maybe convince yourself with the black arrows delineating these kind of small little gray-white lesions, which are leading to the atypical foveal reflex, as you astutely mentioned, throughout the posterior pole in the right eye. And agreed, the nerve vessels and the media were completely unremarkable. And Yusuf, I'll stick with you. Do you mind if you describe this OCT macula image for us?
Sure. So it looks like the posterior hyaloid face looks normal. Inner retinal layers look pretty normal, but the outer retina looks disrupted with some loss of the ellipsoid. Yeah, I'd go with that.
Yeah, chef's is perfect. So you can really see that the ellipsoid zone, I don't know if you can see my cursor, but you can see the continuity of it in the parafoveal region. But then if you're following it, you have loss of that ellipsoid zone subfoveally in this patient. And the red arrow shows how the ellipsoid zone was preserved in the kind of parafoveal region, but subfoveally it's lost. And then Yusuf, just one more, I promise. Do you think you can describe this image for us as well?
Sure, so it's a autofluorescence image of the right eye. This looks like it has normal fluorescence, same with the vessels around there, but in the peripapillary region and macula, it looks like there's some hyper AF in a wreath-like pattern. The mid-periphery and periphery looks normal.
Awesome, fantastic. Yeah, you nailed it. So in the kind of peripapillary as well as in the throughout the macula, delineated here by the white arrows, this fundus autofluorescence image demonstrates hyper autofluorescence kind of throughout the posterior pole. That's fantastic. And here's an IVFA, and maybe one of the more senior residents, anyone in the room can take a stab at this IVFA if you don't mind.
Why don't we go to one of the PGY5s? I did see Marco. I'm going to put him on the spot.
Sure. So this is an IVFA of the right eye. Disc appears normal, vessels appear of normal caliber. There does appear to be discrete foci of wreath-like hyperfluorescence over the macula diffusely and peripapillary retina.
Wow, that's fantastic.
That's perfect for the Royal College oral.
Royal College. There's a late phase IVFA, as Marco astutely mentioned, demonstrating this hyperfluorescence delineated by the white arrows here that correlates to those lesions that we saw in Yusuf's beautiful description on the FAF. No real leakage. I know you have to have multiple images here, but tell you there's no leakage. And Marco astutely mentioned there's a wreath-like configuration to these lesions. So all that in mind, we'll put up the second poll question, which is, what is the most likely diagnosis for our mystery case 3? The first answered choice is acute posterior multifocal placoid pigment epitheliopathy, or AMPI for short, punctate inner choroidopathy, multiple evanescent white dot syndrome, or birdshot chorioretinopathy.
Thank you to
I'm going to give that a couple more seconds to run there.
guiding us to the answer.
We do have a bit of a mix here. I'm going to end the poll for you.
Awesome. Yeah.
Okay.
That's perfect. So everyone, some people chose each answered choice, but most people going with AMPI. And thank you to everyone who contributed there. I'll say the answer is actually C, multiple evanescent white dot syndrome, or MUDS. So we'll talk about that further. MUDS is one of the white dot syndromes which typically affects young myopic women. It's characterized by unilateral blurred vision with photopsia, some flashing lights, and as well as a central or paracentral scotoma. It is thought to be due to an autoimmune or autoinflammatory etiology. However, the exact pathophysiology is yet to be delineated. It's typically a self-limited disease, with symptoms usually resolving within 3 to 6 weeks. And before I go on, I just really want to thank Dr. Aubin's team for the University of Montreal for providing us with the case details and images, and you can find their publication about this case in the Canadian Journal of Ophthalmology in the citation below. So MUDS has been reported already through a variety of immunizations. So there's been a case of MUDS following influenza immunization by Dr. Cunningham's team, as well as a case of MUDS following COVID-19, similar to Dr. Aubin's case published in Ocular Immunology and Inflammation. So we do know that COVID-19 mRNA vaccines increase the spike-specific T cells and the binding antibodies in serum as early as 10 days, which was published in 2022. And as we know, T cells do play a significant role in autoimmune diseases all across the body, including uveitis. So an elaboration and robust T cell response that is upregulated by these mRNA vaccines presumably play a role in patients who develop these immune reactions following vaccination.
So to provide a context to these cases that we're talking about, I just wanted to take us back for a moment to March of 2020 when the COVID-19 pandemic hit. Obviously, to say that this disrupted healthcare and our whole way of life would be a major understatement. There was lots of panic and disruption to everyday life. But that all kind of changed in December of 2020 when vaccines first became available. So that's, first of all, a very rapid development of vaccines that were then widely rolled out. This huge medical success provided hope to many people, but it also sparked trepidation because mRNA vaccines, although they had been in the works for many years, were considered a fairly novel medical technology. As well, vaccines were approved initially on an emergency basis, given the COVID-19 pandemic, and there wasn't an availability of long-term safety data. So there was both hope and fear at the same time. Today, we have 4 COVID-19 vaccines that are approved in Canada. There are many more throughout the world, but the ones that we'll really speak about, the 2 main ones are the mRNA vaccines manufactured by Moderna and Pfizer-BioNTech. We also do have 2 viral vector vaccines in Canada that are used to a lesser extent, the AstraZeneca vaccine and the Janssen vaccine. So just to briefly touch on this, mRNA vaccines derive an antigen from the actual SARS-CoV-2 spike glycoprotein, whereas the DNA vector vaccines carry a DNA that then encodes for this glycoprotein within the adenovirus vector. Both vaccines induce a very similar immune response, where toll-like receptors, inflammasomes, and other cytokines are upregulated, causing an immune response and an inflammatory response within the body. This includes both a B cell response that leads to the formation of antibody secreting plasma and memory B cells, as well as Austin mentioned, the important T cell response, where Th1 related cytokines, TNF alpha, interferon gamma, IL-2 are upregulated. And it's very important that we receive a second dose as well as further boosters to both amplify production of these immune cells as well as to tailor the specific immune cells that are upregulated. So as mentioned, there was no long-term safety data on these vaccines when they were first brought into the population. I just really want to again underline that the overall rate of ocular vaccine-related adverse events is very, very low, much less than 1%. However, in the years since these have come to the market, some adverse events have been reported. Most commonly, these are anterior uveitis, herpetic keratitis, specifically reactivation of pre-existing herpetic disease. There's quite a wide literature on cranial nerve palsies, especially Bell's palsy, and there have been some reports of corneal graft rejection in patients who have undergone previous transplant. Interestingly, similar ocular adverse events have actually been reported both after COVID-19 infection as well as after vaccination. So sometimes delineating about which may be associated with more ocular adverse events is quite difficult. There are no current defined criteria on how to define vaccine-associated uveitis. However, in the literature, it's most commonly thought to be any uveitis or ocular adverse event that occurs within 28 days following immunization. And that's the definition that we've used here as well. In the past few years, a few large-scale population-based studies have come out looking at uveitis following COVID-19 vaccination. The first is an Israeli study that was published in Ophthalmology that reviewed over 2.4 million people who received both doses of the Pfizer-BioNTech vaccine in 2022. They looked at non-infectious uveitis following immunizations, and they found that the risk of developing non-infectious uveitis was 3.9 per 100,000 vaccines after the first dose and 3.6 cases per 100,000 vaccines after the second dose, both within 21 days of immunization. They found that uveitis was most common within 14 days of the vaccine, and that those who had a history of uveitis, perhaps not surprisingly, had a higher risk compared to those who did not. It was a very small increase. When they looked at the standardized incidence ratio, it was 1.3 to 1.6 times amongst those who had a history of uveitis versus those who did not. This study was also very interesting.
What's the rate per 100,000 just in general?
That's a great question. And I was just about to say that they looked at a 2019 reference population in Israel. So they looked at their claims kind of database in 2019, and they found that when you looked at the incidence ratio for age and sex matched controls, there was about a 1.3 times increased incidence following the COVID-19 vaccine in that population compared to 2019. So, the incidence of uveitis is different among different parts of the world. So it's difficult to say an exact number, but when they did look at the ratio, they did find that it was increased in this population following the vaccine. So that does seem to be a veritable bona fide increase compared to just the general population at baseline. This chart from that same paper shows that, the most common site of uveitis was almost 91% anterior uveitis, with very few cases of intermediate posterior or panuveitis. And all of these patients did undergo a workup. In over 50% of the cases, there was no underlying risk factor, so it was felt to be idiopathic uveitis in the setting of COVID-19 vaccination, whereas there were some patients who were otherwise HLA-B27 positive or had Behçet's disease or other, uveitis syndromes. I'd also like to draw your attention to the fact that the best corrected visual acuity was very, very good, ranging kind of from that 2020 to 2040 range when you look at the error as well. So these patients were mainly anterior, mainly idiopathic, and almost all associated with very, very good vision. More recently, Edmund Troy's team has looked at a much larger database. They looked at the CDC vaccine adverse event reporting system that looks at over 2 billion doses of the vaccine given in over 40 countries. And they again reconfirmed that anterior uveitis was the most commonly observed type of uveitis following these vaccines. And when they compared Moderna to Pfizer to the Janssen vaccine, there were similar rates and presentations of uveitis between the vaccine types. Because this was such a large-scale study, they didn't have very many particulars. However, when they looked at the crude reporting rate of uveitis following the vaccine, the incidence was again very low, about 0.3 to 0.6 cases per 1 million doses. They found that uveitis was most common after the first dose, although when it presented after subsequent doses, there was a slightly shorter time to onset. So perhaps there's a, that elaboration of the T cell response is more primed and ready to go. They kind of hypothesized about that.
So as Seema mentioned, anterior uveitis is far and away the most common type of uveitis after COVID-19 vaccination. However, posterior uveitis, as we've already seen in this talk, though rare, can happen after COVID-19 vaccination. It is more common, though, in patients with known uveitis or autoimmune diseases who have already presented to us, as demonstrated by Dr. Kilmartin's team here in ocular immunology and inflammation. So here are the different types of COVID-19 vaccinations. As we know, there's Pfizer, Moderna, as Seema already outlined. You can see here that there are a number of different types of posterior uveitis that happen after various types of vaccination. There's the entities such as acute macular neuroretinopathy, or PAM, as well as AMPI, which a lot of people already kind of thought that the previous case was. That can also happen after a Pfizer vaccination. MUDES, as we've already seen, and also conditions such as azure and herpetic uveitis has been demonstrated following COVID-19 vaccination. This publication did note that there were more posterior uveitis entities after the Pfizer vaccination. However, the large caveat is the Pfizer vaccination was disseminated much earlier and much broader than the Moderna vaccination. So there may just be a more chance of having uveitis because you had a higher chance of having the Pfizer vaccination. Now, there are three proposed mechanisms of post-immunization uveitis, especially related to the COVID-19 vaccination. The most common mechanism that has been postulated is molecular mimicry, where a vaccine's antigen resembles the uveal cell peptides that would trigger an adaptive immune system reaction. And that has been postulated in a number of different publications. The second most common mechanism that we found in our literature review was a previously sequestered self-antigen was activated by our innate and adaptive immune system and those cells following immunization. That has not been demonstrated in any laboratory studies, though, and well, neither of any of the mechanisms. However, that has just been postulated as a theory behind these immunization uveitis entities. As well as an oversecretion of inflammatory cytokines has been postulated secondary to vaccination, again, leading to T cell recruitment, as we've been discussing previously, due to the vaccine's T cell upregulation. And here we have a lovely image about molecular mimicry that was provided by Dr. Dursko, where we have a T cell response related to an antigen that resembles one of our uveal cell peptides. So we can see how this can be upregulated based on the antigens that were presented by the vaccination itself. Now, we've been talking a lot about the COVID-19 vaccination, so we have another case to kind of keep us engaged here. And this is a case that was published by Dr. Kaplan, and a big shout out to one of our superstar PGY1s, Famita, for leading the charge on this case report publication. The fourth case we have here is a 30-year-old Filipino man who presented to Dr. Kaplan with pain, redness, photophobia, and floaters in both of his eyes. Systemically, on review of systems, the patient did note that he was having some headaches, not really localized to any part of his head, but just overall headaches, not feeling well as tinnitus in both of his ears. He had no past medical history or past ocular history of note. His visual acuity on presentation was 2100 in his right eye and 2150 in his left. There was no RAPD and his pressures were within normal limits. He did have some findings on his slit lamp exam. There were some fine KPs on his cornea as well as 1+ anterior chamber cells. On dilated fundus examination, the patient had 1+ vitreous cells, some trace vitreous haze, as well as multiple serous detachments in both eyes. And we'll get a better look at some of those attachments here. And these are some beautiful OCTs taken by Dr. Kaplan. I was hoping one of the possibly other PGY5s or PGY4s can maybe take a stab at this imaging modality.
We'll let one of the seniors go in the room.
I'm happy to try this as well. So we have OCT findings evident. So basically, posterior hyaloid appears within normal limits, though there are punctate areas of vitreous opacities. The inner retinal laminations appear preserved, though there does appear to be multiloculated areas of subretinal fluid, as well as a bacillary layer detachment in both eyes, and evidence of significant outer retinal atrophy with ELM and EZ loss.
Perfection, as always, Marco. That's perfect. So we have these multiple pockets of subretinal fluid, which we can see with the delineated by the white arrows, as well as that splitting of the photoreceptor layer, as we now know is called a bacillary detachment, as Marco mentioned. And Marco, sorry to keep you on the spot if you're already available, if you can just describe this imaging modality for us.
For sure. So late phase FA demonstrating evidence of again, pooling in these multi-loculated areas, some over the peripapillary retina and others over the macula, multiple discrete, again, loculations basically of pooling on the late stage IVFA.
Sound like a recording, but perfect, Marco, exactly. So you have a late phase IVFA here in both eyes, demonstrating that hyperfluorescence and keeping it pooling in those little pockets of subretinal fluid and bacillary detachment. You also have those pinpoint areas of hyperfluorescence as well, with staining in the macula, more so in the left eye than the right. And so this is the last poll question for our audience. I was hoping to ask what you think the most likely diagnosis is for this mystery case number 4. Do you think this patient's presenting with central serous chorioretinopathy or CSR? Or do you think that they're presenting with birdshot chorioretinopathy? Third is, do you think this is VKH? Or 4, do you think, or D, do you think this is diabetic macular edema? The poll question's up. Just hoping you can give your best shot at what you think the diagnosis is.
All right, we've got some consensus here, so I'm going to end the poll early.
Awesome. Wow. Oh, perfect. Amazing. So
We can go home now.
So Dr. Kaplan and all the audience agrees that this is most likely VKH. So VKH is a granulomatous inflammatory disorder where the pathophysiology is much more delineated compared to MUDES, where there's a target of melanocytes in the uvea, as well as systemically in your meninges, skin, and hair. The ocular manifestations of VKH include panuveitis, serous retinal detachments, and optic disc hyperemia. And those serous retinal detachments, as Marco astutely mentioned, are called bacillary detachments, or splitting of the photoreceptor layer. VKH has a very strong association with HLA-DR4, which interestingly was positive in this patient. And the pathogenesis was thought to be due to the Th1-mediated autoimmune reaction to antigens found on said melanocytes. And again, big shout out to our superstar PG1 Fermita for writing this up and getting it published in American Journal of Ophthalmology. And thank you to Dr. Kaplan for allowing us to use these images. So VKH has, as shown previously, that elaboration of the T cell response following COVID-19 vaccinated patient may lead to exacerbation of inflammatory disease responses in diseases like VKH, which are T cell mediated. And notably in DR4 positive patients, this may increase the risk of VKH flare following immunization. But this wasn't really actually related to the COVID-19 vaccination. This was actually after an influenza vaccine. So this leads into our next point, that uveitis can happen after non-COVID-19 related vaccinations. Uveitis has been demonstrated to have a temporal association to a number of different vaccinations following vaccination. In 2016 out of Missouri, there are actually 289 cases of vaccine-related uveitis over a 26-year period, with hepatitis B vaccination being the leading cause. And we can see here the different types of uveitis that can happen after non-COVID-19 related vaccinations. That even vaccinations for Hep A, Hep B, HPV, measles, MMR, and probably most commonly the influenza vaccination. A number of different uveitis entities have been demonstrated to be following these vaccines.
So, as Austin's mentioned, vaccine-associated uveitis is not limited to the COVID-19 vaccine. However, vaccine-associated uveitis does share a common characteristic in that it is typically responds well to treatment and relatively easy to treat. As mentioned, the most common finding after a vaccine in terms of uveitis is anterior uveitis. And like most of the anterior uveitis that walks into our clinic, it responds well to a short course of topical steroids, so typically prednisolone acetate several times a day for a few weeks. These rare cases of severe uveitis or posterior involving uveitis may necessitate, however, systemic treatment, including prednisone orally. Even in these cases, it's important for patients to know that if they present to care and they're treated promptly, they still have a very, very good chance of maintaining good visual acuity and having excellent resolution of their symptoms. And to kind of prove this point, I'd like to point us towards a recent publication of a patient who had the COVID-19 vaccine and shortly thereafter developed a pigmentary inflammatory chorioretinopathy. So you can see here on the left-handed panel of images, you can see the kind of punctate subretinal, chorioretinal areas of hyper autofluorescence and hyperfluorescence on late phase IVFA. This patient also had OCTs in the top panel demonstrate, again, disruption of the outer retina in the subfoveal region. They presented with decreased visual acuity to about 20/60, about 1 month following, in the 1 month following the COVID-19 vaccine. This patient was treated with prednisone 60 milligrams, and within a few weeks had reconstitution of the ellipsoid zone and resolution of the chorioretinal spot. So even in patients who develop more atypical severe uveitis, they can still have very good outcomes. That kind of leads me to the message that we should be giving to our patients when they come to our office. First of all, the risk of COVID-19 remains greater than the risk of immunization. And that remains true even today in this era of less virulent strains of COVID-19. Again, most cases of vaccine-associated uveitis are mild, respond to topical treatment, and associated with good vision. A particular subgroup of our patients often has concerns about COVID-19 and immunization, and those are our chronic uveitis patients, especially those who are already on immunosuppressive treatment. These patients in particular actually should strongly consider vaccination. We now have information specific to this group of patients recently published in ophthalmology by Dr. Acharya's team. They looked at a large claims-based database from the US of insured patients. So these are actually quite similar to our Canadian patients, and we can draw many parallels. They confirmed that in these patients who are immunosuppressed, they have a higher risk of COVID-19 infection, particularly if they're using systemic prednisone or TNF inhibitors. Moreover, these same immunosuppressed patients who are unvaccinated, should they get infected with COVID-19, have nearly 5 times higher incidence of hospitalization and nearly 3 times higher incidence of death following infection. And again, amongst these patients, if they are treated with systemic corticosteroids, they're at much higher risk. This is a a table from that same paper that shows, again, when we look at hospitalization, infection, and death, treatment with systemic corticosteroids carries the highest associated incident rate ratio for adverse events. And this really drives home the point for us as ophthalmologists treating these patients on a long-term basis that systemic corticosteroids should not be our long-term treatment. Even today, this is a more recent paper that looks even in this kind of post-Delta strain era of COVID-19, when COVID-19 is thought to be a little bit less virulent. This still remains true that we need to get these patients off of systemic corticosteroids and onto more definitive treatment for their non-infectious uveitis. In these immunosuppressed patients, they often wonder, when should I time my vaccine? Is there any impact from my systemic immunosuppression upon the immunogenicity of the vaccination? Among the most common IMT agents that we use, there has been some concern about how to time vaccines. So amongst patients with who are on prednisone, there is some thought that it can impact the humoral immunity. So the general guidance is to taper that prednisone to less than 10 milligrams if possible prior to vaccination. However, we know that patients, again, who are on prednisone are at the highest risk, so because they're typically sicker patients. So we need to weigh the risks versus benefits of early vaccination to protect against COVID-19 versus the potential that the vaccine may not be as effective in those times. So that's a case-by-case decision. There had previously been some thought in the methotrexate world that the humoral immunity may be reduced in the 2 weeks post-injection. As many of us, as we know, methotrexate is given on a 4-week basis. However, more emerging reports seem to suggest that there's actually not as much benefit as once thought to withholding methotrexate. So certainly we shouldn't be withholding methotrexate for greater than 2 weeks, because that's associated with no benefit from the vaccine perspective and actually increases the risk of flare. So again, on a case-by-case basis, but we can likely keep giving patients methotrexate as needed. For our patients who are on TNF-alpha inhibitors, such as adalimumab, there does seem to be a change in the humoral immunity, but this is more quantitative, not clinically significant, so they can continue their therapy and receive their vaccinations. And finally, for those who require rituximab or other anti-CD20 inhibitors, we do know that the humoral immunity is reduced for the first 3 months of rituximab therapy. So we should be very diligent to vaccinate these patients prior to starting rituximab therapy, or if not possible, to wait till at least 6 months of therapy has been initiated. If these patients are undergoing vaccination for COVID-19, it is very reasonable to monitor them closely for that first month. This is not only helpful because we know that is when vaccine-associated uveitis may first present, but it's really important in the therapeutic relationship and may help alleviate some patient anxiety and mitigate vaccine hesitancy. So we really recommend that you see your patients as frequently as needed, both for kind of clinical therapeutic reasons as well as for counseling in that period. In patients who have a history of severe uveitis or have had previous flares with vaccines, you could actually consider giving pre-treatment with topical steroids, and that's something that our group has done with good success. So especially in those patients who may have, for example, HLA-B27 associated or recurrent uveitis, or if they've had a history of a vaccine-associated flare, giving them a few days of steroids before the vaccine and then following them closely. We haven't had any episodes of flare-up with this regimen. And finally, borrowing from the cornea literature, in patients who have a history of herpetic eye disease or who are at high risk of corneal graft rejection, you may consider bumping up their antivirals from a suppressive dose to a treatment dose around the time of vaccine. And you may increase their topical steroids as well to mitigate the risk of corneal graft rejection. So to summarize, anterior uveitis is the most common manifestation of COVID-19 vaccine-associated uveitis. Posterior uveitis has been reported, but it is exceedingly rare. Most cases do present in that 2 to 4 week period after immunization, and that's when we should be on the highest alert. We can continue immunomodulatory therapy for our patients during vaccination, but we should have conversations with them about how to time it. And finally, we know that systemic corticosteroids increase the risk of COVID-19 infection and should not be considered as a long-term therapy. So we should keep that in the back of our minds when we're treating patients in this era of COVID-19.
And some take-home pearls for all the ophthalmologists on the call and all the residents. We want to recommend COVID-19 immunizations, especially if there's no contraindications to their immunization. We want to reassure patients as well that these ocular side effects are exceedingly rare, typically are mild with a visual acuity, typically in a 0.3 logMAR ratio, and unusually treatable with topical treatment or systemic immunomodulatory therapy. We want to include an immunization history as well in our routine review of systems for all these uveitis patients, as we see that that can be maybe the only cause of these uveitis entities. And we want to encourage uveitis patients to remain up to date on routine immunizations if planning immunosuppression, and don't fear regular immunization if they are planning to be on these systemic therapies. And we also would like to minimize long-term systemic corticosteroid use, as that can increase the morbidity for these patients. We want to thank Dr. Oban's team from the University of Montreal for providing that amazing MUDES case following COVID-19 vaccination, and really just allowing us to present that case. I also want to thank Dr. Kaplan and his team, as well as FAMITA, for allowing us to present the VKH case after influenza vaccination. And really a massive thank you to all the healthcare providers, first responders, and really all the residents as well who are working, maybe redeployed during the peak of COVID-19, and really helping disseminate all these COVID-19 vaccinations to get us back to our new normal. So thank you, everyone.
Thank you, that was excellent.
Thank you, guys. That was excellent. Dr. Dershko, the floor is yours.
So I want to make a couple of comments about some of the points that we made during the presentation, and to clarify something. So Dr. Lloyd had asked about the incidence, that study that looked at the incidence of uveitis post-COVID vaccination. It was a standardized incidence ratio, and I'm not a statistician, so I can't explain exactly what that is, but basically we're comparing the incidence rate of uveitis in the 21-day period, where they were looking for uveitis, compared to an annual incidence rate, and so it's adjusted for that reason. So the question was, what is the standardized or the usual incidence rate of uveitis? And in that population in Israel, it was 45.7 cases per 100,000 person years, and that's what we generally quote. So the incidence of uveitis is about 50 per 100,000. So that's the number to remember. And so the numbers were just slightly higher for post these patients who were vaccinated. It was 66.8 cases per 100,000 person years, but actually it was the numbers we were looking at the first 21 days post-vaccination. So it was truly just slightly higher, and the numbers are a little skewed because we were looking at most of the uveitis occurred in the first 21 days. So effectively, there's no large increase in incidence of uveitis. And I also wanted to clarify that and all my patients who were treated for uveitis all had vaccinations. I was in touch with rheumatologists to manage any adjustments to the immunosuppressive medications, biologics, and nobody had a flare of uveitis. And we did pre-treat some patients with anterior uveitis with some topical steroid drops and watched them carefully, as Seema had mentioned. And again, just to emphasize that patients do much better when they're treated for uveitis with immunosuppression rather than prednisone, and prednisone also increases the risk of severe consequences from COVID-19 infection. So again, just to remember, again, immunosuppression is very safe for these patients. And we do have a couple of questions, so I'll...
Yeah, so there's a question here from Dr. Lichter. She saw a patient who developed an NAION following vaccination. Now, have you seen anything similar? She's wondering if this is coincidence, because I think, you know, that's also not an uncommon condition that we see. Any thoughts from the panel?
So I haven't personally seen that, but it might have not ended up in my clinic, but certainly neurologic I guess complications, if you want to call that, post-COVID-19 vaccinations occur. Usually it's cranial nerve palsies. I don't think NAION is all that common, but I would have to defer to my neuro-ophthalmology colleagues, and maybe our residents have comments from your experience.
Yeah, I mean, definitely not something that I've seen myself, but in reading about the COVID-19 vaccine and associated sequelae, there were some case reports that there was a temporal correlation. I think Dr. Lichter's point really speaks to the fact that it's very difficult to establish causality versus correlation for all of these cases until we look at these large population-based studies that do, show us that there may be an actual overall increase, and we're looking at, millions and billions upon doses. But even then, we can't really establish causality. I agree with Dr. Dershko that that's one of the more rare neuro-ophthalmic side effects that's that's cited in the literature. It was interesting in doing this research to see what the obligations are for reporting these kind of adverse events following vaccination. Sometimes these things are reported as case reports, but don't necessarily make it to, Health Canada or the CDC until they happen on kind of higher frequency. So there may be some things that we don't have clear answers about because that case reports, and that makes it very difficult to establish causality. But it has been reported that I'd seen once or twice at least as a case report.
And we do have a comment here from Dr. Oben with the Montreal experience. sounds like they've seen a few. Sorry, it sounds like they've seen a few optic neuropathies post-vaccination as well.
Yes,
And she, yeah.
Thank you, Dr. Oban, for mentioning. They have an excellent paper about toxoplasmosis, so looking at infectious uveitis following vaccination. And certainly, her comment's very salient that in these patients who have potentially vision-threatening disease or have had a previous flare-up, these can be very, very severe. So it's certainly reasonable to consider anti-toxoprophylaxis, and we're really grateful for her for her team to share their experience. Because although these things are rare, if they do affect a patient and impact their vision, it's obviously hugely impactful on their quality of life. And so some of these decisions have to be made on a case-by-case basis. And again, that patient rapport, following them around that period is so key. Thank you, Dr. Aubin.
And thank you for joining from Montreal.
Yes, so nice to have you on the round.
Okay, well, we don't have any further comments or questions. I do want to thank you guys for an excellent presentation. It does arm us with some very helpful and practical information when we counsel these patients in our offices. And these are conversations I think we've all had and will have. So I do appreciate it. Dr. Dushko, thank you for your leadership on this. Dr. Imami, our newest ophthalmologist in the city of Toronto, congratulations. And Dr. Austin Pura, thank you for a wonderful talk. There's one more comment actually from Dr. Tarani at the American Academy of Pediatric Ophthalmologists, right? AAPOS. This week, similar rates were reported for cranial nerve palsies as well as uveitis post-COVID vaccination in the pediatric population. So that's good to know. That's helpful.
And some of those conversations may be a bit more challenging with pediatric patients because we know that pediatric patients often do quite well with COVID-19 infection. However, it's not benign for them to have COVID-19 because they spread it through households, they spread it to grandparents, for example. And so again, reiterating to those parents who may be concerned that at least our experience so far has been that uveitis at least is treatable, associated with good outcomes, and being willing to monitor those families kind of around the vaccine period may go a long way in terms of rapport and supporting families through this difficult decision.
Agreed. Thank you. So with that said, we'll wrap up the rounds. Thank you again, guys. Excellent presentation, excellent comments. Thank you for your time. Enjoy the rest of your Friday, everyone.
Thank you very much.
Thanks, everyone.
Thank you, everyone.
Bye.